Thank you very much. My name is Liao. I'm a medical oncologist from the University of Chicago. Today, I'll be talking about tailoring treatments to your tumor genetics. So we're moving towards an era of precision medicine and personalized medicines. And what that means is that we can use the tumor tissue or the blood sample to determine the genetic code of the tumor via next generation sequencing and other technologies, and come up with a molecular report of the tumor's characteristics that can then open opportunities for new treatment options like targeted therapies and immunotherapies, and also clinical trial opportunities. So in other words, understanding your tumor's genetic makeup could help us find new treatment options for you. So to understand what this means, I'm going to take you to a quick crash course on cancer genetics. So within a tumor cell, the genetic code is contained in the DNA, and this is packaged into genes. The DNA gets transcribed into RNA, then they get processed and ultimately translated into proteins, which are the key players of the processes within the cells. We use the term genome to describe the entirety of the genetic code of the tumor. And when we say tumor genomics, we mean the tumor's genetic code. So these proteins play into the key processes of the cells, including all these complex regulatory and signaling pathways that can then help the tumor cell grow, survive, make new blood vessels, and even become resistant to cancer treatment. So here are some examples of the changes in the genetic code, which we call genomic alterations. So you can have mutations, which is like having a typo in a word. You can have expression, meaning that the gene is always turned on to make the protein. You can have gene amplification, meaning having multiple copies of a gene in the genetic code. You can have gene loss, meaning that a gene is deleted from the genetic code. And then you can have fusions and rearrangements in which a part of a gene is fused to a different part of the gene, leading to the downstream pathways to always be turned on. Not all genomic alterations have consequences. There are driver mutations, passenger mutations, actionable alterations have a potentially biological role in the development of the cancer. Variants of unknown significance, or VUS, alterations, unclear risk cancer development. So germline alterations are genetic changes that you're born with, and these can be transmitted to your children. On the other hand, somatic alterations are genetic changes that are acquired during your lifetime, and they only affect the tumors, and they're not passed on to your children. So we use molecular profiling to test for these genomic alterations. So like I said before, we can do these tests from the tumor tissue itself, and we can also do it from the blood, also known as a liquid biopsy, which measures the circulating tumor DNA that the tumor shed into the bloodstream. So this is an example of what a report looks like. As you can see, they show you potentially actionable genomic alterations. They show you both somatic and germline alterations, and they show you other important biomarkers, such as tumor mutation burden, microcellular instability, that may predict for response to treatments like immunotherapy. So what are the common genomic alterations that we see in neuroendocrine tumors? This is one of the most comprehensive studies in DNA sequencing for neuroendocrine tumors. And the study showed that for high-grade neuroendocrine carcinoma, these tumors tend to have higher tumor mutation burden, so more mutations per cell. And some common alterations include genes like TP53, KRAS, RB, APC, and MYC. For low-grade neuroendocrine tumors, these cells are generally characterized by lower tumor mutation burden, and common alterations include alterations in genes like MEN1, ATRX, DAX, and etc. And the study showed that about 49% of patients have a potentially actionable alteration. So some examples are high tumor mutation burden, BRCA alterations, FGFR alterations, and HER2 alterations. So if you think about genomic alterations, we really have many different situations. Drugs of proven benefit that can directly target that genomic alteration. You can also have drugs of theoretical but yet to be proven benefit. And then you can have drugs of proven non-benefit, meaning the drug has been tested and doesn't work. And finally, you have those alterations for which there are no targeted drugs available yet. So this is an example of a drug of a proven benefit to a given alteration. So this is pembrolizumab, a PD-1 inhibitor immunotherapy treatment for patients whose tumor have a characteristic called microsatellite instability or mismatch repair deficiency. So this is the phase 2 Keynote 158 study. Here is what's called a waterfall plot, which plots the change in the size of the tumor. And so this study included 233 patients, including 7 neuroendocrine tumor patients. And overall, pembrolizumab led to a response rate of 34%, with 9.9% of patients getting a complete response, and a duration response of greater than 4 months in 78% of the patients. So a very, very durable response. Caveat is that this is for all comers, and only 7 neuroendocrine tumor patients were included in the study. But nevertheless, this is an FDA-approved treatment for patients whose tumors have MSI high or mismatch repair deficiency, including neuroendocrine tumor patients. Another example of a drug with proven benefit is using pembrolizumab, the same immunotherapy drug, for patients whose tumors have high tumor mutation burden. So this is a different cohort of the same study showing that pembrolizumab treatment for patients with high tumor mutational burden led to an objective response rate of 29%. Notably, the response rate in neuroendocrine tumor patients with high tumor mutation burden was 40%, and the duration of response that lasted for greater than 2 years was seen in 67% of patients. So this again is another FDA-approved treatment option for any solid tumor that has a high tumor mutation burden, including neuroendocrine tumor patients. Yet a third example of drugs that have a proven benefit are drugs that target alteration called NTRK, so NTRK fusions. So this is a drug called entrectinib, studied in phase 1 and phase 2 studies in all solid tumors, and it led to a response rate of 57%, including a complete response rate of 7%, and a median duration of response of 10.4 months. And this study included 3 neuroendocrine tumor patients. So again, this drug was given FDA approval for any solid tumor that has an NTRK fusion, including neuroendocrine tumors. Now we're moving on to talking about drugs that may have a theoretical benefit, but the benefit has not yet been proven for neuroendocrine tumor patients. So one example is HER2, which I've definitely seen in my patients. So HER2 can be amplified, and that can lead to cancer growth and survival. And the significant thing is that now there are many, many drugs that can target HER2. These are called HER2-targeted therapies. These treatments have really revolutionized the treatment of many cancers like breast cancer. So for instance, HER2-positive breast cancer used to have the worst prognosis, and now there's so many different HER2-targeted agents. It's really changed the natural history of HER2-positive breast cancer. So what about using these HER2-targeted drugs for neuroendocrine tumor patients whose tumors have a HER2 amplification? Well, we don't know. So that's why I say it's a theoretical benefit, but yet to be proven. But this is prime opportunity to consider clinical trials. So for instance, if a patient's with a neuroendocrine tumor patient's tumor has a HER2 amplification, then we should really encourage looking for a clinical trial they can enroll in for one of these HER2-targeted therapies, and many clinical trials will allow patients with neuroendocrine tumors to get on as long as they have the right alteration. Then moving on to the next category, which are drugs of proven non-benefit, meaning that the drug was tested against an alteration and it just didn't work. So this is an example of pembrolizumab immunotherapy in patients with well-differentiated neuroendocrine tumor from the phase 2 Keynote 158 study. And as you can see, overall, the response rate is pretty low, it's 3.7% in this population. If you think pembrolizumab targets the PD-1 and PD-L1 axis, so you could imagine that patients with tumors that have PD-L1 expression would respond to pembrolizumab since that's where it targets. But turns out it's not as simple as that. So if you look, patients with PD-L1 expression actually did not respond. So the response rate was 0% to pembrolizumab. On the other hand, there were a few patients who actually responded to pembrolizumab whose tumor did not express PD-L1, which is what pembrolizumab was supposed to target. So this is an example that just because a drug can target an alteration doesn't mean that it's always going to work. And finally, we have those genomic alterations with no targeted drugs available yet. These include some of the most commonly seen alterations in neuroendocrine tumors, such as TP53, RB, MYC, MEN1, DAX, and ATRX. So this really highlights the significant unmet need for us to do further research for neuroendocrine tumor patients in terms of both drug discovery and clinical trials. So to summarize, by understanding the tumor's genomics, that could potentially open door to additional personalized treatment options, including clinical trial opportunities. This gives new treatment options, new hope to our patients, potentially helping our patients live longer and with better quality of life with neuroendocrine tumors. Understanding tumor genomics may also predict for response to standard therapies and sometimes may give prognostic information for a given patient. We also know that tumors evolve over time, and therefore periodically resampling the tumor to reassess the genomics may offer further opportunities to tailor our treatment. And finally, as you've all seen, we really need further efforts in research for neuroendocrine tumors in terms of both drug discovery and also in terms of conducting clinical trials to further validate the benefit of some of these off-label targeted therapies. Thank you.